Thank you so much, Chairman. It was a great pleasure listening to Professor Sesha take us through the history of diabetology in America, in India. And we had a similar story in America. And sometimes you read about people in the journals, and it's really nice to see the foundation workers in diabetes and pregnancy that I've read so much about. I also heard about the tenacity with which you pursued your dream, and nothing worthwhile comes to fruit without tenacity. I thank the organizers of this great 6th World Congress of Diabetology in Diabetes India for inviting me and for thinking it fit and proper to showcase the ADA president in your proceedings. The organizers are to be commended for putting together such a pristine product. I was looking through the program, and the coverage is particularly impressive. It is pertinently clinically focused with an appropriate sprinkling of basic science and molecular biology and diabetes technologies. About the time I was listening to Professor Sesha's history, I was put in mind of our own history in America. 75 years ago, Dr. Cecil Stryker of Ohio wrote these words when encouraging his colleagues to come together and found the American Diabetes Association. So Dr. Stryker was one of the founders and the first ADA president. He said that the patient suffering from the syndrome of diabetes mellitus is the reason for the existence of this association. His medical, social, and economic problems are our problems. Since he represents one of a group consisting almost, in 1940, 3/4 millions of people with similar individuals, the enormity of these problems becomes obvious. Since the incidence of diabetes and the mortality from this disease are increasing in spite of modern developments in medicine and surgery, a concerted attack on diabetes is essential. That was the premise upon which the founding of the American Diabetes Association was based. 1940, less than 1 million Americans with diabetes was considered a crisis worthy of declaring war. Today, we have 29.1 million Americans with diabetes. And the trajectory of the diabetes burden from less than 1 million in 1958 to nearly 30 million in 2014 through 2015 is almost reminiscent of a viral or infectious contagion. We do not know what accounts for this conflagration and phenomenal rise in diabetes rates. Understanding the basis for the modern epidemic, indeed pandemic of diabetes, presents unique opportunities for discovery for young and fit minds engaged in diabetes research. It also presents enormous challenges of taking care of a projected 592 million souls on the planet who would be afflicted with this disease by the year 2035. Diabetes consistently numbers among the top 10 killers of humanity in any society. These are the 2012 WHO data showing diabetes up there. But what many readers will miss when they look at this chart is that diabetes contributes enormously to the top two, the leading cause of strokes and the leading cause of cardiovascular disease. In fact, patients with diabetes no longer die from diabetes. They die with diabetes, but from cardiovascular disease. So why do we see so much diabetes in our time? Even in ancient times, diabetes was recognized. Ancient Sanskrit literature, the Ebers Papyrus from Egypt, all make allusions to the existence of a disease characterized by excessive urination, non-healing lower extremity, gangrenous ulcers, etc. But it was not appreciated at the time that it was an epidemic. Nothing by way of the ancient literature indicates that physicians at the time were confronting an epidemic. But in our time, it is not a controversy. We have a pandemic. Like many chronic diseases, the occurrence of diabetes represents an interplay between genes and the environment. Both type 1 and type 2 diabetes are predicated upon a genetic substrate on which there is superimposition of environmental triggers. If we knew the specific environmental triggers, we wouldn't be here today discussing what to do about diabetes, because we would have nailed it. So the lack of total comprehension of those environmental triggers that convert a normoglycemic individual, and most people with diabetes were born normoglycemic. There is the rare monogenic diabetes of neonatal age group, but those normoglycemic individuals then at some point in their lives develop diabetes. We in the Diabetes Prevention Program have genotyped all 3,000 participants in our study looking for the diabetic gene, and we've been disappointed because more than 60 SNPs, single nucleotide polymorphisms, across the entire human genome have been identified with no one single one representing the silver bullet. So, genomic studies and proteomic studies and the omic sciences will help expand our knowledge, but they will not provide the silver bullet to attack diabetes. By contrast, the environment pulls the trigger for the diabetogens to orchestrate their metabolic disruptions, and nowhere is the role of the environment more pertinent than the story of the two Pimas. Pima Indians of Arizona and Pima Indians of Mexico in the United States. Pima Indians of Arizona in the United States and Pima Indians of Mexico. Both have genetic similarities. Both came from Asia, crossed the Bering Strait thousands of years ago. One group got tired and stopped in the United States. The other group kept moving south to Mexico. Today, the Pima Indians of America have the world's highest rate of type 2 diabetes. By age 35, more than 50% have diabetes. Their cousins in Mexico, 6% prevalence of diabetes. The difference, Pimas in America, BMI 33, Mexico, body mass index less than 25. Physical activity, 3 hours in America, more than 40 hours a week in Arizona. So obesity and physical inactivity lead the top of the environmental risk factors for diabetes. But there are many others that present opportunities for discovery. Data from China and elsewhere showing the potential effects of air quality, for instance, in serving as an environmental trigger. Endocrine disruption chemicals like phthalates, polychlorobispheноls, plasticizers, etc., that we consume in large numbers are waiting to be nailed as specific etiological factors. Urban transition, urbanization, and other as yet uncharacterized triggers abound in the environment, and there are opportunities for discovery. Talking about urbanization, I started by showing that diabetes has always been among the top 10 killers in all societies, but if you now break down the 2012 WHO data by socioeconomic distribution across the globe, low-income countries, you do not yet find diabetes coming up among the top 10. As those low-income countries transition into lower middle-income countries with just a little more money, diabetes shows up in the top 10. And as those countries expand and become technologically savvy and grow more middle class, they become upper middle income countries, diabetes shoots to the top. And as this society settles, like has occurred in most Western societies, with no rapid transition, the diabetes stabilizes and comes down a little bit lower. That represents an opportunity to not recapitulate the same mistakes. So developing countries must raise awareness for diabetes and prophylactically intervene at a societal level to reverse this coupling, this amalgamation of progress with an inevitable surge in diabetes. There are phenomenal global challenges, particularly in low and middle income countries. Screening and diagnosis represent a challenge. Effective treatment, control, and monitoring is another challenge. Surveillance of complications and a focus on effective prevention also is a challenge. In Southeast Asia, an estimated 75 million souls have diabetes, and 39.6 million may be undiagnosed. In Africa, nearly 60% of people affected by diabetes are yet undiagnosed. The American Diabetes Association and all global authoritative associations concur that a fasting glucose of less than 100 represents the upper limit of normal. Greater than 126 milligrams per deciliter represents diabetes and should be repeated for confirmation. Oral glucose tolerance tests may also be used to diagnose diabetes. Beginning 2010-2011, ADA also introduced the use of hemoglobin A1C for diagnostic purposes, the cutoff being 6.5% or greater. I caution that use because there are limitations and pitfalls, including racial and ethnic variations, lack of global standardization of the A1C measure that must be referenced. It must be done in approved labs and referenced to the DCCT standard, and a real economic barrier. In the US, costs $35, and I understand that it could be as much as 450 Indian rupees, 7,000 Nigerian naira, and 400 Mexican pesos. Every year, our organization, the ADA, brings out the Bible for diabetes management. We call it Standards of Medical Care in Diabetes, focusing not just in America, but on the globe at large. We represent specific pillars of diabetes care that should be a comprehensive effort rather than isolated. We advocate individualization of care, effective monitoring by the patient and physician, appropriate diabetes education, a focus on non-pharmacological lifestyle interventions, plus appropriate use of medications, usually mobilized in a stepwise fashion. And most importantly, we do not want complications to sneak up on patients or on the physicians, so we proactively screen and surveil for them. Monitoring is specifically done using A1C, laboratory or point of care, now acceptable. Self-monitoring by a variety of glucose meters, simple and easy to use. The principles of self-monitoring are evolving because the test strips are the limiting barrier to access, very expensive on a cumulative basis. So the frequency can be negotiated based on which agents are being used. Agents that do not cause hypoglycemia, so non-insulin and non-sulfonylureas, the patient may test less frequently, particularly if they are economically challenged. Whatever frequency your patient uses, it will be unconscionable not to impress upon them the importance of the monitoring, so they should record the sugar numbers from home and bring the record, and all of us should studiously be seen to be perusing and studying the pattern of the glucose fluctuation so they know that the numbers that they've been recording for us are important and are used for clinical decision making. In the United States, we have ready access to diabetes educators and dietitians to whom the physician can outsource the responsibility of lifestyle intervention. In most of the rest of the world, that luxury is unavailable. So the doctor must himself or herself become the diabetes educator, the lifestyle interventionist, the exercise prescriber, and the dietitian, which means we should increase our knowledge base in those areas. Then medications. The rule of thumb about medication is that they must be layered upon a platform of lifestyle intervention, and they can be mobilized in now a fairly united manner instead of the erstwhile previous stochastic approach. Metformin on lifestyle intervention, evidence-based escalation of care, the evidence being hemoglobin A1C remaining at goal, which currently the ADA advocates should be less than 7%. And then going down a cascade until the condition is controlled. If necessary, mobilization of insulin in various combinations. Even with all of this, and in well economically resourced countries, the Eureka study and enhanced data indicate that across the globe in the so-called Western world, from the US to Australia, Belgium, France, Germany, Russia, Spain, Sweden, more than half of the diabetic patients do not reach goal. despite national health programs and diabetes organizations pushing the frontiers, they don't make it. That leads to complications that are very expensive to treat. In 2012, our organization, ADA, estimated $245 billion of US money going to diabetes care, driven by a variety of complications. Screening for those complications is therefore important. Eye exam at the time of diagnosis of type 2 diabetes and within 5 years of diagnosing type 1 should include dilated fundoscopy and tonometry for glaucoma. Foot exam to test for neuropathy, and microalbuminuria to screen for nephropathy. Appropriate targeting of blood pressure and lipid management also come into focus. But the challenges in developing countries are enormous. Most do not have their own local drug manufacturing capacity. Most lack the appropriate expertise. It was only in the mid-80s that Dr. Sasha was telling us about the development of appropriate expertise and training program here in this great country. So we have all these problems, and the A1C is not routinely available. And people have been focusing on drugs, and we had no drug before 1922. We had insulin, then now we have a plethora of medications to treat diabetes, and the more drugs we develop, the more diabetes we see, and therefore drugs are not the answer. You look around the world, there are people with pre-diabetes that number in the hundreds of millions. Pre-diabetes represents an opportunity for intervention, a wide window of opportunity that may last as long as 10 years before full conversion to diabetes. In the US, we launched the diabetes prevention program that unequivocally demonstrated that type 2 diabetes can be prevented by lifestyle or metformin intervention, and the effect was consistent across the various racial ethnic groups. We've now reported that after following the cohort for nearly 20 years, the lifestyle group continues to express lower rates of diabetes compared to the placebo group. The new study, new phase we call the DPP outcome study, and approximately 50% of our cohort still have not developed diabetes, and they joined the program with pre-diabetes. And the classical canonical estimate is that pre-diabetes progresses to type 2 diabetes at a rate of 10% per year. And if that rate were to be unmitigated, then in 10 years, 100% would have progressed to diabetes. And in 16 years, we have 50% who have not progressed because of lifestyle intervention. They lost weight, 7 kilograms within 6 months. They gained back half of the weight. And as at the time of this lecture, our lifestyle participants have matched the metformin group in their weight, so there is no further weight loss. But they have continued to be protected from diabetes. We call this the legacy effect. And I understand and saw in the program that there is a lecture on the legacy effect. Very interesting phenomenon. Here in Chennai, Dr. Ramachandra and his group have also published a seminal study, the IDPP, Indian Diabetes Prevention Program, where they advanced and expanded our observations by testing the hypothesis of dual therapy, lifestyle plus drug, which unfortunately has been repeatedly shown to be a failure with both metformin and pioglitazone. So lifestyle is the key. Adding a drug on lifestyle did not develop additional efficacy. Why does lifestyle work so well? The classical approach, fat reduction and reduction of a variety of toxic adipocytokines. But there may also be epigenetic or epigenomic factors. The TCF7L2 gene, transcription factor 7L2 gene, is the leading diabetogen in the world, accounting for 47% of type 2 diabetes in Iceland and close to that number across the globe wherever it's been tested. In the diabetes prevention program, individuals who were homozygous for the TT allele, the diabetogenic allele, the risk allele, had 81% increased risk of developing type 2 diabetes from pre-diabetes compared to those who were negative for the gene. But if those individuals were randomized to the lifestyle arm, the hazard ratio was decreased by 70%, So the gene was silenced by environmental intervention. People with pre-diabetes progress to type 2 diabetes at a rate of 10% per year. We do not know at what rate people who were born normal progress to pre-diabetes, the halfway house. So in the POP ABC study, we enrolled people with risk for diabetes by having family history but normal glucose and follow them to pre-diabetes and show that whether they are white or black, the rate was about 10% per year. So we've added information to the proximal stages that transition from normal to pre-diabetes occurs at the same rate as deterioration from pre-diabetes to normal. The predictors of incident pre-diabetes in our study included male gender, weight gain, some glucoregulatory impairments like insulin resistance and beta cell dysfunction, and biobehavioral factors including excessive eating and not enough exercise. Quickly, adiposity measures, the red bars were those who progressed, and the blue bars, those who did not progress. And you can see every measure of adiposity shows that higher levels predicted transition from normal to the halfway pre-diabetes. Disposition index was lower, as was insulin sensitivity in people destined to move from normal to pre-diabetes. So the approach to the global diabetes epidemic presents an opportunity to nip it in the bud, stopping it before it shows up, by screening and identifying as many at-risk individuals as we can, aiming for a 5 to 10% weight loss has been demonstrated to be effective, focusing on caloric restriction and abandoning hope about using a pharmacologically based approach unless forced to do so, behavioral self-monitoring, a targeted physical activity of about 30 minutes, 5 days or more a week, close contacts, and screening for comorbidities. We have to be creative. I was visiting professor to the University of Sao Paulo last year, and one of our colleagues there, Professor De Souza, told me that she had somehow motivated middle-aged diabetic patients and pre-diabetics to play soccer, which was a national passion. She's been trying to get them to exercise, and they refused. When she said soccer, they just jumped up and changed their uniform and were kicking around. They didn't know they were exercising. They were playing soccer. She now checked, and their hemoglobin A1C has decreased significantly after 12 weeks, so it is now built into lifestyle intervention. I was so impressed by the program. I joined them when I was there every morning for soccer, and that's me in case you missed it. So we need to encourage the world to develop low-cost lifestyle intervention models not delivered by expert dietitians but by lay people, community support programs, urban designs that are friendly to physical activity, training of a lot of people, introducing diabetes prevention in the elementary and high school curricula. And eventually, I want to see us grow community diabetes prevention centers strewn all across our zip codes and territories where people can just go there and have their physical activity and their counseling. Imagine a world where diabetes can be stopped from affecting 600 million people. The productivity, the limbs that will be protected, the eyes that will continue to see for people, the heart that will keep pumping, the brains that will be protected from strokes. All of those advantages present a compelling opportunity for continuing to do what Diabetes India is doing in the world's largest democracy. And the world can borrow a leaf from what you are doing to establish their own patterns of diabetes intervention, customized to local environmental realities, but with a single purpose: to make diabetes a thing of history, to improve the lives of people with diabetes. Thank you so much.